Hello, everyone, and welcome to our webinar, Increase Revenue by Better Understanding Healthcare Payment Practices. All lines have been muted. The webinar will last 30 minutes, and we will have dedicated time after the presentation for Q&A. If you have questions throughout, simply type them in the comments section, and we will address them during the Q&A time. This webinar is being recorded and will be sent to each participant afterwards. Our speaker for today is Annie Boynton. Annie is the Director of Compliance for CVG Corporate, a sister company of iCare Leaders. She has served in the health information management field for more than 20 years across providers, payers, and educational capacity. We appreciate you taking time out of your busy schedule to join us today. At this time, I will turn the webinar over to Annie.
Thanks, Teresa, and thank you everyone for joining this afternoon. As Teresa mentioned, we have a pretty ambitious agenda today of talking about increasing revenue by better understanding healthcare payment practices. And I specifically want to focus on a couple of points around billing compliance, denials, appeals in particular, how to work denials and appeals, and how that fits into an overall billing compliance program, and talk about a couple of simple steps that we can use to strengthen our case when we go after an appeal, and to give you some tools as far as legalities and regulations are concerned that you can use to your advantage. So when we talk about navigating denials and appeals, I think it's pretty obvious to say that they do add up. And the MGMA, the Medical Group Management Association, has actually put quite a bit of money into researching the cost. And according to a white paper they did about 3 years ago, it's between $25 and $30 to manage the average denial. So if you think about the average medical practice, those really can add up when you talk about day after day, the number of denials that come through the door. And this can be for a number of different reasons. It could be for something simple as a transposition of a patient's member ID. It could be because of a clinical issue, or it could be because of a regulatory or compliance issue. So it's very, very important to have a very strong denial management process. And there are a couple of ways that we can go about that. We can outsource that. That's usually the most expensive portion. We could use an all-in-one system that would help to bring that in-house, save us money, and also to better control that denial management process. Now, a couple of reasons that we do see denials, and this is by no means an exhaustive list, but things like incorrect or underpayments, contractual adjustments, even claims edits to a certain degree, service that lacks prior authorization or referral, UR issues, ERISA issues, duplicate submissions, eligibility issues, Medicare secondary payer rules, timely filing, and then, as I alluded to earlier, errors on claims. So part of a strong denial management process really is trying to anticipate some of these causes and trying to avoid them on the front end. That would be the very first step when we talk about how to implement, how to really take control of denial management. And then prioritization, of course, because there is not going to be a one-size-fits-all answer. There's not going to be an instant fix. You probably won't even see a fix within a month or even 6, depending on the volume of denials that you're dealing with. A high dollar often equates to high effort, and the same can be said with low dollar. Low dollar denials or claims could be considered or connotated with low effort, and you really have to pick one as a starting point. You have to decide, well, do you want to work those high dollar claims, even though they may have take a lot longer to turn around, or do you want to work those low dollar, low effort claims, because you'll theoretically you would have a much faster turnaround with some of those, and hopefully much faster cash influx with some of those. So again, you really have to sort of look at this from a practice standpoint, overall overhead standpoint, and then applying the Pareto principle or the 80-20 rule can really help as far as your decision making is concerned. But prioritization is certainly key. When we talk about the snapshot for appeals, I actually want to step back a second and talk not just about appeals, but about claims processing. And make sure that everybody understands that claims are processed in a variety of manners through payers in this country. The majority of payers out there try to use what's known as auto adjudication systems, and there are usually 3 levels of review for the claim prior to the point where you get to a denial and then have to go back to an appeal. So when we talk about the claim itself, your initial first pass of the claim, you submit the claim to the payer. Generally what will happen is it's scanned and intake by a computer, right? So optical character recognition or OCR readers are really quite common when we deal with auto adjudication systems in the payer world. And that's one of the reasons why you'll notice when you do look at a paper form, a CMS 1500 or 1450, you'll notice that they're usually in red. And that's again for benefit of the scanners, because the scanners don't look at the red ink, they look at whatever's in the field. So anyway, you submit the claim, goes through the computer. If something doesn't make sense to the computer, it doesn't mean that it's going to be automatically rejected. Usually what will happen is it will be kicked out of the computer system and sent over to a pair of human eyes as a basic claim reviewer, claim examiner. If it still doesn't make sense, it may, at that point, it will either go to another reviewer, or it's even possible that you may see that it goes to not necessarily denial, but they may deny it, or they may just submit it back saying that there is an issue with the claim or what have you. So sometimes you can go through and do a reconsideration. If it's a true denial, then you have to go through and work an appeal. And the appeal process, by law, every state has to have some level of appeals process. Every payer is required by law to offer an appeal. Now, the question being is, how many stages or phases of that appeals process are they required to offer? Now, according to the law, really, it's usually 3 levels of appeal. You have a first level that's an internal review. So the payer gets your appeal. They look at the letter that you send. They re-examine the case and make a decision. The second level of appeal, generally that's going to end up involving a clinical person, maybe a nurse case reviewer, maybe a medical director, and then third level external appeal, often referred to as external review, and sometimes we hear the phrase IRO or independent review organization. That really is a third party, a neutral third party or objective third party that's going to look at that appeal and then make a determination. So 4 steps for successful appeals. First and foremost, one of the most common things, I spent many, many years as a claim reviewer for payers here in my home state of Massachusetts, and one of the most common things I used to see is that providers would send us appeals and they would forget to reference or cite the initial claim that they're actually trying to appeal. This is hugely problematic. So please don't send an appeal in if you're not going to reference the original claim that you're actually appealing, because the payer is going to have no way to track that. And that usually ends up being another automatic denial, right? So don't waste one of your opportunities simply on a clerical error. Second is drafting a clear argument within your appeal letter. I cannot stress the importance of a refined, strongly worded, and educated and crafted appeal letter. Because too often what we see in the industry is that a provider will simply use a template or a canned appeal letter, and all they're doing is replacing the doctor, the date of service, and the patient's information, and it's the same script over and over again. Usually what I try to recommend to the practices that I work with is that you should have a customizable, easily customizable appeal letter for a variety of different specialties, for a variety of different issues. If you insist on using templates, have a number of them, not just one that you rely on. I'll talk more about that as we go forward in the session. Make sure that you are supporting your argument with compliance issues, but if you need to, with regulatory or legal items, or by clinical means. And clinical means could be a variety of things. It could be a Pub 100 reference from Medicare. It could be a CMS or CPT assistant article or AHA article, some type of peer-reviewed journals from a specialty organization. So again, clinical means any type of supporting information that can help support and strengthen your argument to help that payer change their mind, if you will. And don't be afraid to cite the law. We'll talk a little bit more about this, but oftentimes people think they have to be a lawyer to cite federal regulation. In reality, that is not true. You know, and I'm going to give you a couple of citations that you can use in your appeal letters moving forward, just to make sure that everyone's on the same page, that the payer understands what your interpretation of the regulatory statutes are when it comes to appeals, and that you understand where the payer is coming from. Sometimes citations of the law can actually help you open up a door of conversation with the payer, because so much of a strong denial management process really is about communication. And what we then tend to see in the industry is that really the denial management process gets whittled down to this adversarial, you know, us versus them situation. We see enough of that in healthcare. You know, when it comes to working at denial and trying to appeal that decision, at that point in time, we really do need to have open up those barriers and to sort of lift that veil that payers are notorious for trying to throw down to obfuscate issues. And then, of course, the last one is really a no-brainer, but make sure you're filing appeals on time. Every single payer in the country has a limit, a filing limit for appeals. Don't be late, not even by a day. Documentation. For what we do for a living, generally when we think about documentation, we're thinking about provider documentation. But when we talk about denial management, when I mention documentation, it really does take a different spin. And that is, as you begin the process of working an appeal and trying to have a provider or a payer rather reverse their decision, you need to be documenting every single contact you have with the payer during that event. So names, dates, times, even brief synopses of conversations, those are going to be critically important. And I always recommend that you treat every appeal as the potential to land in front of a judge. Remember, the medical record is a legal document, but also the patient's financial record also can be used in a discoverable way when we talk about payment legalities. So don't let physicians be their own worst enemy. And what I mean by that is, a lot of physicians, when you ask them what it means to appeal a claim, there's probably not a lot of they're going to be able to give you other than, you know, you're trying to get a payer's to reverse their decision. If they're able to go any further in that, we'll bully for them. But generally, most doctors aren't that educated about the appeals process. So this is the time for anybody who's working on this side of healthcare, on the business side of healthcare, to really not only advocate for their doctors, but also to be able to educate them to help them understand the process of claims, denials, and appeals, and that they can be timely and that they can be costly. As I alluded to earlier, successful appeals really do require a strong and very clear letter behind them, right? So this is when we get into really thinking about what payers do currently, right? Generally, payers are going to respond with ambiguous non-answers, and it usually takes the shape of a form letter. Some payers maybe put a little bit more effort to them, but again, and I'm generalizing here, but in my experience, the larger the payer, the more bureaucracy they have behind them, the greater the chance that they are likely going to use this style of communication in the form of a form letter. When you're drafting appeals letters, think about if you're addressing compliance issues. Believe it or not, compliance and regulatory issues are really becoming almost neck and neck with clinical and medical issues when it comes to appeals. Are you citing legal sources and peer-reviewed evidence in your letters? If you're not, then you're missing out on a very, very large motivator for that payer to change their mind. If you're relying solely on a template, as I mentioned earlier, this is the time to start reconsidering how you're wording those templates. Are you using just one template of a couple of paragraphs, or are you using a more robust template or letter that gets into specialty-specific issues and asks who your reviewers are, what their qualifications are, what their recommendation is if they're going to deny this particular service? These are all things that by law you have a right to ask and a right to know from the payer. So refinement of the appeal letter is really just the beginning of creating that strong denial management process. We talk about the ACA or PPACA. Remember, that's the Patient Protection Affordable Care Act. It adopted the ERISA standards, and ERISA has been around since the 70s. And it uses the ERISA standards as the minimum for internal appeal standards for payers. And then on top of that, it adds a layer of additional consumer and provider protections. The consumer protections are really what I want to focus on, because it's very important to understand that if you do have a claim issue that becomes a denial and you have to appeal the decision, it's really important to consider having a patient sign off on an authorization form. Now, this has nothing to do with HIPAA. The authorization in this context really gives, you can kind of liken it to a power of attorney, in that it gives the practice the ability to act on behalf of the patient in financial matters. Otherwise, without this authorization, what you'll likely hear from the payer is that they cannot share certain information with you. Even though you're the provider, they cannot share certain information with you because of the fact that there are these new consumer protections that are in place around patient financial information. Another very important regulatory standard or statute from the Affordable Care Act is 45 Code of Federal Regulations, Section 147.136. It's the internal claims and appeals and external review process definition from a federal standpoint. And they talk very specifically about appeals, and it makes it very, very clear that providers have rights to appeal. So an appeal or internal appeal, it is where by internal appeal means a review by a plan or issuer of an adverse benefit determination, and does go on to explain a little bit more. And I gave you the source here if you're curious, or if you'd like to read more about the regulation. You can just take that section and even Google it, and you'll land on one or two free legal sites that will bring up that law for you. But the most important thing to remember is that at a federal level, providers have a right to appeal. This is also true at the state level. There may be state laws that are more stringent or stronger, if you will, than the federal regulation. And then in those instances, usually what will happen is the state regulation will supersede the federal regulation. In those few states that may not have any state regulation about appeals, obviously the federal law would take precedent here. So everybody can appeal. Everybody has the right to multiple levels of appeal. Everybody has the right to external review should it come to that. Now, timely filing. Obviously, when we think about appeals, we want to think prospectively, and we want to think about the idea that, you know, the best offense is really to avoid some of these things. But if that being said, the next piece we would be looking at is making sure that your claims are filed on time, right? Unless there is some type of, you know, national disaster, or even if you think about the hurricanes we saw last year, like Hurricane Harvey, for example, where you may see that we may have seen that some practices were underwater. All right, so if that's the situation and the practice is underwater, and you have to talk to the payer, right? Because ultimately it will be up to the payer to decide whether or not they're going to help you out. Some of this I do find, and again, I'm generalizing, but I have found that some smaller payers tend to be more adept and amenable to working with an organization as opposed to some of the larger payers. But it doesn't hurt to ask if there's something that's gone wrong in the practice and you have a justifiable reason why you haven't been able to file, talk to them, because ultimately you'll be throwing yourself at their mercy. Obviously, try not to be late, but if that's the case, talk to the payer. Late claims, late appeals, again, like I said, I mean, you're really throwing yourself at the mercy of the payer. Legally, they have the right to say no way. So if there's a valid, explainable reason, make sure you talk to them about that. Try to prevent any of these issues by filing claims as quickly as possible. Generally, I mean, we like to see filing on a daily basis. Some practices will do this depending on the specialty, weekly or even monthly in batch. But generally, filing as quickly as possible helps to avoid some of these timely filing issues from a claim standpoint. And from an appeals standpoint, just the same. Remember, every payer is going to have their own process around appeals and what they expect for filing limits. And make sure that you're not late on those. Well, the filing process, again, you know, ideally the claim itself is going to be filed ASAP after the service is rendered. Supporting documentation, consider sending that with your initial submission. You know, you have to become a details person. You have to make sure that you have an excellent tracking system. If you have any doubts whatsoever, don't be afraid to send via paper mail with certified mail return receipt. And again, keep in mind that most payers have a 180-day filing limit to file an appeal. but that could vary. So if you have a question about it, make sure you inquire with the payer directly. And then, of course, the authorization that I alluded to can be very, very important to include in your appeals submission packet so that you can represent your patient throughout the entire course of the appeals process. One thing that I get asked an awful lot is about customer service. And what I find is that providers generally have unrealistic expectations regarding what customer service that a payer can and cannot do. You have to remember that customer service representatives, these are not the people who are actually dealing with the claims processing. They're not even the claims examiners. They are simply manning the phones, if you will. They are usually sequestered from the actual claim examiner. They may not even be in the same building, the same state, or the same country, depending on the payer. So again, claim service reps, or customer service reps rather, they generally are also not going to be coders. They're not going to be billers. There's a really a very small list of things that customer service can do for you. And when it comes to it from a billing standpoint, generally your list of questions that you can ask a payer customer service rep is, have you received my claim and has it been paid? Those are about, if you're going to ask anything more than that, I mean, those are really about the only two things that I would ask. If you're going to ask anything other than that, you need to be prepared for the fact that they may not be able to help you. Now, if they can't help you, where do you go? Well, usually what I would recommend is that you watch out for provider advocates or provider relations reps. A lot of payers will send those out to practices, send those individuals out to practices, and keep in mind their sole job is to ensure that the providers are satisfied with the payer's service. So if you have, a pattern that's trending with one particular payer, and you know your payer representative is, or your provider advocate is, those are the people that you want to be talking to about some of those higher end issues. Another point that I find very confusing for the provider community is the payer contract. The payer contract is the ace in the hole when it comes to claims processing. Really important information in there, and what I find all too often is that the physicians who sign these contracts tend to keep them under lock and key. You know, you would think in some cases that it's a treasure map. It's got the map to the Temple of Solomon or what have you in there. But the thing is that the contract is going to tell you absolutely everything you need to do from the practice standpoint in order to file claims successfully. It's going to set up the appeals process. It's going to talk about the fee schedules, co-payments, co-insurance, deductibles. There will be causal language in there talking about waivers and oftentimes the inability to waive co-payments. They are just chock-a-block full of useful information, and it's really, really crucial that a provider who signs those contracts allows their billing staff to know what it is that they are contractually obligated to. The best way for a biller or coder or any billing compliance program is really to have access to that contract so they know what it is they have to actually comply with. Now, we talk about legal contents, and you have to keep in mind that when we look back to 45 CFR 147.136, and if you read into probably subparagraph 4 in there, you keep reading through there, it actually talks very, very specifically about the concept of full disclosure. And the ACA is really trying to get the payer community to fully disclose things like who's looking at claims, right, and appeals, right, what their qualifications are. Was the review case or condition specific? Did the payer reviewer use some type of peer-reviewed journal, clinical resource, evidence-based findings? So again, all of this being aimed at transparency, right? And the ACA really did put a huge burden on the concept of full disclosure in the effort to have full transparency from payers and even with providers, right? So again, when we talk about drafting a strongly crafted appeal letter, legal citations can automatically incite a higher level of review, as that first-tier reviewer is likely not going to be able to handle those legalities. So be as accurate as you can be in your citations, but again, I say take that with a grain of salt, because if the citation is inappropriate, if you're doing it repeatedly, right? If you're doing it in an abusive manner and you're constantly referring to the incorrect citation, chances are it's not going to be taken seriously. You do it once, what it does is it opens up the conversation to the payer. If they should say, well, we don't follow this regulation, your next option with the payer is to open that discussion and say, well, what do you follow? And what this does is it helps us to start lifting the veil that the payers throw down, right? We know that there is this very thick veil that payers try to segregate or separate themselves from that provider community, and it's almost like they intentionally try to obscure their processes. So, this is an opportunity for you with a strongly crafted appeal letter citing a legal source. It is an opportunity to at least open a discussion as to what their regulations they're following, what their reviewers' qualifications are. Are they, if you're an eye care specialist, if you're ophthalmologist or optometrist, obviously you don't want a medical director who specializes in family practice or pediatrics to be reviewing those claims, right? And so you do have the legal right to know this, and that's why I gave you that legal citation from the ACA 45 CFR 147.136. Very, very important, and can be very useful when you are drafting some of those appeals letters. And then, of course, the authorization. Remember, the goal is for full disclosure, right? And what the ACA is really trying to help us do is get to a point where we don't have to ask those questions, that it will just be common knowledge as far as the payer operations, and that would be a beautiful thing. Right, increases in external reviews. Keep in mind that the ACA also sets aside this concept of the IRO, or the Independent Review Organization, and there is an actual association called NARO. It's a National Association of Independent Review Organizations, and there's a really, really important quote that I have on the screen here that came from the white paper, which I've linked to as well, that talks about the fact that it says very specifically, recently the healthcare industry has witnessed an increase in the number of administrative external appeals which don't require medical judgment, but instead demand legal review of policies, procedures, and applicable law to ensure a health plan is properly applying legal provisions to healthcare denials. Okay, what they're saying there, I think, is really fundamental in that we're seeing an uptick in the number of appeals that are based on compliance issues, not simply clinical practice. So having a basic knowledge of the law concerning claims and appeals can be very, very helpful when you go to actually argue some of these with your payers. Right. Remember, external review is also stated in 45 CFR 147.136. And I've given you the text here on the screen regarding the external review. Remember, the concept is that at a federal level, regardless if the state has a process in place, federal law does state you have the right to an independent review, right? Neutral third party, who's going to look at this decision, look at the claim and make a decision. There are pros and cons about IRO. These definitely have to be weighed and calculated at the practice level. Not every claim is going to be worth going to all the way to an IRO. So there should be a threshold that's decided on internally. Additionally, when you think about this, remember, IRO is once a decision is made, both parties are required to abide by it. So regardless if they find the payer's decision or the patient's in the patient's favor, rather, everybody has to agree upon that. So, and the other point about IRO is that the provider has got to exhaust the payer's internal appeals process before it's eligible. So if the payer has a 3-tier appeals process, you have to exhaust every level before it's eligible. That particular appeal is eligible for an external review. Right. So again, all of this is about helping to learn the payer operations a little bit better. And for every payer that we do business with, transparency is really the key, and it doesn't matter where we practice in healthcare, it's across the board. Right. So a couple of things that we can also do, again, internally to sort of beef up our appeals practices is to know where their payer policies are. For every payer that you do business with, you should be able to go out on the web and find their policies. Gone are the days where payers are going to issue policy handbooks. They used to do that way back when, if you will. But nowadays it's usually online. And as far as policy change announcements, you should have it set somewhere in your calendar every year, whether it's done every year or every other year, when those policy changes take effect, because those right there, your policies carrier-specific manuals, websites. Those are what's going to be the tools that will dictate how you're going to deal with claims processing in the year to come. So again, worst case scenario, you're not sure where to go, you can always go to Google, right? That being said, just because you spent time to look at one large payer, don't make presumptions that every payer is going to have the same exact policy. And what we tend to see is very common assumptions around things like the use of modifier 50, bilateral, multiple units, multiple services, durable medical equipment items, things like that, multiple births. Just because a code is covered with one payer doesn't mean it's going to be covered by all. And really what this is about is again, focusing on the fact that there is homework that the provider has to do to stay a step ahead of those payers, because we don't want to give the payer any excuse to deny our claims. So due diligence, a little bit of research, and construction of a strong denial management program can help us to have cleaner claims on the first pass. So your final product for your appeal packet is going to have some kind of method of tracking, preferably on your appeal letter, right? It's going to reference the original claim form. If the payer has one, their appeal form, any supporting documentation. It could be the medical record documentation. You could use peer-reviewed journals, as we've discussed earlier. And then, of course, a strongly crafted letter of appeal that would be signed by the physician. Right, so in conclusion, I think what I will do is turn it back over to our moderator.
Okay, the slide that Annie has on our screen right now is just kind of a summary that shows you the all-in-one solutions that we offer with iCareLeaders, and it's just a great reminder that to really help with your appeals and denials process, if you have all of your information together in one location with a system that's very comprehensive, such as what we offer, that it will make that entire process much easier.
And to your point, Teresa, I would say having this all-in-one system is really, really helpful because, like you said, everything is in one place. It's not like we're going to go chasing through multiple systems. You have analytics there that can help with pattern detection so that you can pick out the payers that may be your quote-unquote problem children. And it's just an incredibly useful tool for the practice to have everything in that one solid place.
Definitely. As far as questions that came in, the only one that we really had come in was related to the slides. Will these be available to print or download? We do not email out the entire slide deck, but what we do is we do send out a link to this entire webinar. So you can fast forward and look through it as you need to get any of the information that you specifically need. And if you have any questions, once you receive it, feel free to just hit reply, and we will make sure we get answers for you on that. And then as far as the next slide that Annie has for us, that's going to talk about the next webinar that we have coming up. And that is with Mike Schmidt, and he is going to be talking about what you need to know regarding MIPS and MACRA. That is going to be coming up on June 13th, I believe. And he's definitely our resident expert. So feel free to sign up for that at iCareLeaders.com. Again, if you sign up and you can't make it for some reason, we will also be sending out the recording for that. And then just our final slide is related to our iCareLeaders One User Summit. And this is going to be the first time that we're bringing together all of our business units, our companies, into one big user conference. So for any of you that are on the phone that are members currently using iCareLeaders products such as MyCare iMedicWare, MyCare Integrity, MyCare or MedFlow, any of those, you'll definitely want to attend. There is an early bird registration that ends tomorrow. So if you want to save some money, make sure you sign up by tomorrow. And also, if you bring 3 or more staff members, you will get a $50 rebate off of each of those registrations. We'll also be offering CEUs for some of those classes. So if you're interested in attending, just go to eclsummit.com and you'll learn more information, including the whole agenda that we have for that Friday, Saturday, and Sunday in Orlando. And on that note, it looks like we do not have any other questions that came in. So I just want to thank everybody for your time, and check your inbox in the next few days and you'll have this actual recording. Thank you, and thank you, Annie.